Welcome to this webinar on precision medicine in the community. We're really excited to introduce a fantastic panel today to discuss topics including digital healthcare, disease prevention, and public engagement with precision medicine. Some important housekeeping items to cover first. So this event is being recorded and that recording will be circulated following the event. Please post questions throughout the event in the live Q&A section, and we'll try and reserve the final 10 minutes of this event to answering those questions. We ask that all cameras and microphones remain off through the event. So today's event, I would like to introduce our co-chairs who will lead the discussions for the next hour. We have Sandosh Panhapan, who's the Professor of Cardiovascular Genomics and Therapeutics for the academic lead of the Pharmacogenomics and Digital Health strands of the Living Laboratory for Precision Medicine at the University of Glasgow in the UK. We also have Mark Cook, who is the Chair of the Scottish Brain Sciences in the UK, who developed the infrastructure to deliver research and clinical trials in neurodegenerative diseases. Sandosh, can I pass to you?
Thank you, Jess, and welcome all. Thank you for attending today's webinar on precision medicine in the community. I know that we will have an interesting discussion on the challenges and opportunities surrounding delivery of precision medicine in the community. We have selected a panel with diverse experience who can give an all-round view on this topic and perhaps stimulate quite a lot of discussion. I would now invite Mark, my co-chair, to introduce the panel. Mark.
Thank you. And I would also like to thank everybody who's attended today's event and also the panelists who've given up their times to speak to us. So it's my pleasure to introduce a very eminent panel. So we have Michael Schmidt, PhD, who's the founder, CEO, and Chief Scientific Officer of Savaris Aerospace, who's focused on assessment and solutions applied to humans in space and extreme environments on Earth. Dr. Schmidt is also chair of the Health and Human Performance Committee of the Human Research Programme for Civilians in Space Travel and Space Habitation. Callum McRae is Vice Chair for Scientific Innovation at the Department of Medicine, Brigham and Women's Hospital, and also Professor of Medicine at Harvard Medical School. He's a co-director of Genomic Medicine at Brigham and Women's Hospital and also the director of One Brave Idea, precision medicine program funded by Verily, AstraZeneca, and the American Heart Association, with additional support from Quest Diagnostics. Professor Katsumo Kario is currently Professor and Chairman of Cardiovascular Medicine, Chichi Medical University School of Medicine in Japan. In 2018, he founded the Hope Asia Network to improve the management of hypertension in Asia. And lastly, Holly Etchegari is an Associate Professor and Leader in Genetic Ethical, Legal, and Social Issues for the Interdisciplinary Team in Human Genetics at Memorial University's Faculty of Medicine. He's the Patient Engagement Lead for the Prominence's Strategy for Patient-Orientated Research. So welcome to our panelists, and thank you. We have a number of questions that we decided on in advance to give a good introduction to the topic area to pose to the panel first. As Jess mentioned in the introductions, from the audience, please post any questions you have in the live chat, and then we'll cover as many of these as possible in the final 10 minutes or so of our event. So with that in mind, I am going to hand over to Sandosh for the first question.
Thank you. Thank you, Mark. So the first question is to Holly. And the question is, what role can patient engagement and education play in the successful implementation of precision medicine in community healthcare?
Well, thank you very much. So first of all, thank you very much for the invite. Very nice to be here. By the way, I will say, I just noticed on the slide, I didn't notice it before, that I'm actually in Canada, not in the United States. I'm in the province of Newfoundland and Labrador, just to let our audience know, in Canada. So thank you very much for the invite. So the patient and community engagement, I have a few thoughts. I want to sort of throw out some ideas to get us started and some thoughts that I think will be relevant throughout the next hour, or I hope they'll be relevant in any event, but I'm going to time myself to make sure I'm not too long. So my own bias, I'll be very clear. You heard in the introduction that I am the patient engagement lead for our province. Here in Canada, we have SPORE, or the Strategy for Patient-Oriented Research. And so a lot of my work is very much guided by the principles of that strategy. And so much of the work I do includes patients as partners. And that's kind of the first thing I want to talk about. So the idea of engaging with patients or communities, whatever is relevant in your research or in your clinical initiative, your precision medicine initiative, et cetera, partnering with them to come up with research priorities or health system priorities or precision medicine priorities, et cetera, partnering with them to figure out, well, what outcomes matter? What matters to you in your community, or what matters to you as a patient and a family who's living with a particular condition that we as researchers and healthcare providers want to help, right? That's the whole goal of precision medicine, of course. The other thing about patient-oriented research, however, while patients and families and communities, they are key, and the concept of partnership and co-development, co-creating, we're also co-creating and co-developing things with those other important stakeholders, which may include various healthcare providers. It may include lab personnel. It may include digital people who are experts in digital technologies. It may include governments, municipal, provincial, federal. It will definitely include the health system decision makers. So I actually think that when we talk about patient and community engagement and patient-oriented research, it's about bringing all those stakeholders together and really thinking about what matters. What are the outcomes we should be measuring? What matters to patients, to families, to communities? One of the things that precision medicine makes me think about, and I think we have to address it from, think about it from an ELSI standpoint, or an ethical, legal, social issues, is precision medicine requires us to reconceptualize, I think, how we think about personal health information. I always thought about my own personal health information as being just that, very deeply personal, maybe shared with my family doctor, but maybe not many others. But when you think about precision medicine and all of the wonderful promise it holds, it is asking patients to share their data pretty freely, pretty regularly, and often longitudinally, right? And that's not just sharing the results of, say, a DNA sample or a genome-based test, but perhaps also includes mobile health data, behavioral assessments, and perhaps, and I would think, clinical information from their electronic health records, for example. So, and it's almost like thinking about our data as a social good. So right away, I think that requires the building and maintaining of trust, which I think is an important thing to think about within patient engagement. And I think a real shared decision-making approach when we think about genome-based testing or many precision medicine initiatives. So I think that's very much an element of patient-centered care and patient engagement, right? That idea of shared decision-making. The other few ideas I want to throw out are more broadly related to ELSI issues that I think are relevant in precision medicine, and I think will come out as my fellow panelists talk as well today. One is access, and I think about access in a variety of different ways. So I think first of all about the data that we're accessing to drive this wonderful science. We have to have some equity and diversity considerations, right? So I think we know that many of the data sets that we're using are of people from European ancestry, but we need that knowledge of genetic variation in different ancestry groups, right? In order to identify differences, in disease course, for example, or etiology. I think access can also be related to cost. If we think about some of precision medicine initiatives, they can involve costly diagnostic tests and targeted therapies. Patients can worry and do worry. We have literature that patients do worry about the cost of these and whether or not they're covered by insurance. I think cost concerns can also be related to the risk for unequal access to precision medicine. If we think about particularly marginalized communities who might not have access to genetic testing, even the relatively simple, if you will, single gene testing. Right now in Canada, for example, we're involved with a study of people who are impacted by hereditary cancer syndromes. We're talking to them in 3 different provinces, and just in 3 different provinces, we already see differences in access to genetic testing, to that very critical, I think, pre-test counseling. So I think that's another important facet of access, thinking about access to genetic counseling and testing and follow-up, et cetera. The other access thing I have to note, which just in a recent systematic review was actually reported as the most important concern for patients, and certainly in my work across town halls, various qualitative methodologies and various types of surveys, this has certainly been the case, that people are concerned about the privacy and security of their data, right? So I said, we're being asked to share our data. We certainly live in a data-driven society, I think, right? And people do worry about the security and privacy of their data. So importantly, who will access their data? We have quite a really nice body of research now, I think, public opinion and perception work globally. So we know a few things now about what patients think about that in terms of with whom they want to share their data, who they do not, what they worry about. So I think engaging with patients and communities about those sorts of concerns from an early stage will be really important, because they could ultimately, I think, help us design governance processes and structures that take into account those patient and community concerns. So access is one of my big sort of things I think about when I think about precision medicine. Another one I want to throw out is complexity. I think precision medicine and genomic medicine and sequencing, I think it can be really complex for both patients, families, and their healthcare providers. So it raises questions or LC issues about, the sheer volume of data. What are we returning to patients and families? How prepared are healthcare providers to work with their patients and families on some of these decisions? So I think patients, and we know we have a very large literature now, again, on, for example, secondary findings and what patients and families think about those. So I think it just reminds us again that the sheer volume of data and the potential complexity of it really does require that we engage in shared decision-making, I think, with patients and families, that they're given choices, especially with respect to disclosure and managing those sorts of findings. And then the final thing I will throw out, because I'm pretty sure I'm getting close to end of my time, is implementation. So if we think about some precision medicine initiatives, so let's think about even pharmacogenomics, just for example. We know we have good evidence. It's been shown to improve the safety and efficacy of many medications, right? But I think the implementation has been a bit uneven. So often it has been launched in large urban academic medical centers, right? That serve a big urban community, have a large regional healthcare system. But if you think about more rural community-based health systems, particularly including those that are serving populations of non-European ancestry, I think those systems have been a bit slower to implement pharmacogenomic testing. So the broader issue for me is an equitable implementation of precision medicine initiatives. So I think we need to think about and work with patients and communities and families, and again, those other important stakeholders on the ground, to co-create a variety of implementation strategies. They're not a one-size-fits-all, right? I wouldn't think. If you think about, for example, something that's been perfected and tested in an intervention in a large, say, university-type academic healthcare system, which I'm sure is where many of us work and do our research and initiatives. If you have, say, a care pathway, it's been figured out, it works really well. If you look at the workflows, let's say, in a smaller rural community-based hospital, that workflow may not work there, for example. So I'll finish by saying I think many of these issues really are well served by co-developing and co-designing solutions with all those relevant stakeholders, including patients and families and potentially whole communities, if that's the case. So I'll end there. I'm pretty sure, I hope I haven't gone too far over time, but I hope some of those issues will be relevant in what my fellow panelists will be having to say as well. So thank you very much.
Thank you, Holly. Yeah, that was right on time. I think you covered most of the key areas of or challenges in precision medicine, not specifically just for the community, but also in general across secondary care, tertiary care. But obviously, translating precision medicine to the community has unique challenges. And you highlighted the problems of privacy, access, complexity, and implementation. I'd like to ask you about, so from the patient perspective, it's clear, but I'm just wondering, what about primary care physicians? What are their views on implementing, these complex algorithms? I mean, they would require some help, support, and you mentioned the example of pharmacogenomics. The worry of physicians is increasing burden for themselves.
Yeah, absolutely. It's another key issue, right? And so again, broadly speaking, I will say, I think one of our best chances of co-developing solutions that will work in any local context is to involve those folks from the beginning first. However, if we take a step back, I mean, I haven't gone to this literature in a while, but I know we have a fair size literature. And for many years, primary care providers, if you look at surveys or interviews or focus groups with them, certainly here in Canada, I've been involved with some of those studies from years back. You know, while they see the potential benefits of precision medicine, very quick to see it, many are also very quick to say, I don't know how ready I am. I don't know how confident I am to work with my patients. I need some sort of support. So there have been a variety, I think, of studies and interventions designed. We did one here in Canada called Gene Messenger, for example, years ago to try to help with that. I suspect we still have a ways to go, to be honest. And we know there's a shortage of genetic specialists globally. And so I think more and more of it is moving into, you know, sort of cardiac oncology is a clear area where it is now, and other areas, and indeed into primary care. So I think we have to look to those consortia, health systems that are beginning to do this work. So if you look at Genome England, for example, they're doing some wonderful work with developing training and building capacity in healthcare providers. So I think we do have some work to do there, but I also think working with them can make a difference. And I forget the study. I wish I could remember. It was really a great study done out of the US where they worked with primary care providers and patients and labs who generate the genome testing reports, and they changed the reports to something that providers wanted. What did they need? What would be just-in-time information? What needs to be flagged in my electronic medical record? They also created one for patients that they could access on their patient portal. They were different, but the early indications from both groups were that they were really well received. So it's a good example of engaging that patient-oriented approach to help create something that's usable on the ground. I do think that's key.
Thank you. We have time for one question from any of the panelists. Do any of the panelists have any questions for Holly? If not, I'll hand over to Mark for the next question.
Thank you, and thank you, Holly. That was very interesting. And you know, the next question, which kind of backs into that, is really to get you know, Professor Carrio's view around the level of engagement almost within the community, because the inclusion of the environmental and lifestyle factors into disease prognosis leads us to the influence of preventative medicine. And you know, I'm very, very curious what your thoughts are about what interventions can we make within the community, and how have these progressed in recent years? So over to you, Prof. Carrio. I believe you're still on mute, sir.
Hi, hello. This is Kazumi Kario from Japan. Thank you very much for inviting me. My specialty is the cardiovascular disease. So, may I show first slide? Could you share my slide? I'd like to show you the trajectory of cardiovascular disease in the community. Could you show my slide? Yes, thank you very much. This is the trajectory of cardiovascular disease from the healthy conditions to the worse conditions. So first, from the healthy to from here, this is advancing the age, lifetime. So from here to here, the first event may occurred here. So first event occurred once the recovered, but the recurrence, and also finally death or from the poor conditions. So from the genomic and the lifestyle and the environment, all these affect cardiovascular risk factors. So hypertension, diabetes, hyperlipidemia, and smoking. These the risk factor advance the predisposing conditions. These are the atherosclerosis and the cardiac hypertrophy. So, and organ damage, like here, and some biomarkers could be detected here from in this subclinical phases. So, but finally, some trigger occurred, trigger of the event. So cardiovascular event, ASCVD, atherosclerotic cardiovascular event, stroke, heart, and also the aortic dissection, and also heart failure could be triggered by the big surge of blood pressure. So the environmental factors here, such as the cold temperature in the winter and PM 2.5. So we found the low temperature and the increased PM 2.5 additively increase the blood pressure. So, and also lifestyle, such as acute exercise here, and the mental stress, and the high salt, and the alcohol intake, and poor sleep quality. These trigger the short-term blood pressure surge. So, these acute trigger-induced blood pressure surge on the top of the seasonal variation, day-by-day variation, and also diurnal variation in the morning with the peaks. So, resonance of these all surges could generate big dynamic surge blood pressure, which could be triggered cardiovascular events, especially in the high-risk patient with a stiffened artery. So stiffened artery could not absorb the power of the pulse. So power of the pulse transmitted to the brain or the kidney, and also afterload of the heart. So these are the trigger cardiovascular events. So this is the resonance hypothesis. So we should diverse these risk factors and triggers. So digital technology could be connect chronologically personal health records, and also digital health and behavioral modification and therapeutics, facilitating the lifestyle and environmental modifications. So we can modify these to reverse sodium reduction, and the body weight control, exercise, and stress management, and room temperature control. So these the modification of the lifestyle and also environmental status could suppress the surge, and also here the chronic risk factors. So genotype based the precision medicine, and also chronological biomarker based the anticipation medicine to anticipate the big surge which could be triggered cardiovascular event is very much important for the personalized medicine. So digital technology, especially home blood pressure should be based, because we have a lot of the evidence of the blood pressure, especially measured in the guided the measurement of blood pressure. Home blood pressure measurement is the most important blood pressure measure to predict the cardiovascular events. So on the top of these, the morning and evening blood pressure measurement measured at home, the wearable, especially now the cuffless blood pressure monitoring could be useful for identify the personalized profile of blood pressure variability. This device measures the blood pressure is not it's immature to detect the absolute value of blood pressure, but some blood pressure variability could be detected by such a cuffless monitoring. So it's now the research and development status. So we should we are waiting for the innovative device. So wearable could the device ideally detect various blood pressure surge during the daily life, and big data processing, and also transmission system, and the artificial intelligence will promising to estimate the surge blood pressure here, and the trigger which could be trigger cardiovascular events in future. So genotype-based precision medicine and the hemodynamic biomarker, the blood pressure variability, the based anticipation medicine would provide the personalized, personalized medicine, which could, which leading to cardiovascular event zero in the community. So first, we should screen the high risk patients in the community, and then diagnose the risk factors, hypertension or diabetes, the hyperlipidemia. So after that, we can detect the high risk patients with organ damage or increased biomarkers. So we can provide the blood pressure monitoring to these patients to detect the hypertensive patients with the different high risk different profile. This should be one of the important and then a treatment. So population target, then pick up the disease patients by screening, especially using their home blood pressure, and then the diagnose, they finally treated, and then monitoring. So this should lead to reduce the cardiovascular events in the community. So we are now on the stage of this trajectory. Thank you very much for your attention.
No, thank you. That was very interesting. And if I may just sort of ask a follow-up question to you, but perhaps maybe some of the other panelists might also wish to contribute. In an area like hypertension, do you feel a personalized medicine approach will help with the compliance and concordance that's traditionally been a problem with chronic diseases? How do you get not just the worried well, but everybody to comply and buy into it?
So especially for we have the annual check system in Japan. So we can pick up the high risk patients by measuring in the laboratory, and then we can provide the home blood pressure monitoring. So if the blood pressure variability and the average level of the blood pressure increase above 135, we ask the patient to come to the doctor's office. So this should be from the screening to the medication status. So, but some patients it do not come, but it should be we are now asking the patient to monitor the blood pressure at home themselves. It's not so difficult because blood pressure measurement is non-invasive. So it's a routine of it should be the routine of the daily life.
Thank you. Would anybody else like to come in on this?
I
Sure.
think it's Caleb.
Oh, sorry, Sandosh, I didn't mean to interrupt. Thanks for having me. I would just add, as Kazu said, I think reaching into the community in lots of ways, but particularly using digital flows from the patient, but digital flows back to the patient can help dramatically with adherence and compliance. Just simply because you're engaging the patient on a more regular basis, you can take processes of optimization of therapy that might have taken months and do them really on the basis of the half-life of the drugs. And in addition to that, you can help the patients manage a whole host of lifestyle issues. I would go one step further, which is to say, one of the fundamental problems with blood pressure is that it varies very widely for an individual day to day, within the day. And so really asking ourselves, can we identify predictive markers from well before individuals present with hypertension that allow us to stratify those individuals in very different ways than we have traditionally done? And I think Holly brought this up in her introduction, which is we have to almost reimagine how we think about medicine. We tend to have this sort of point of initiation and then data collection in a sort of episodic and investigator-driven fashion. And ultimately, what precision medicine is about ongoing optimization throughout your entire life course. And Kazu, I think, presented this very nicely at the start with a genome. I would go even further and say it's probably an antenatal genome. That's what's actually setting your trajectory for life, so that a lot of the disease entities that we think about now, you're already funneling stratification into those in a very different way than we currently imagine.
So first, we should identify the high-risk patients and then track the blood pressure variability chronologically. So then by the blood pressure could be used as a measure of the biofeedback to change the lifestyle modifications. So we know how to reduce blood pressure, salt reduction, and the exercise, and stress management, and the body weight control. So by the blood pressure measurement is not only the measure risk factor, but also it could be the one of the stress and the environmental stress markers, which could be used as a biofeedback to change the lifestyle. So monitor chronologically, then go to behavioral modifications should be reduce the risk of cardiovascular events in community.
Thank you. I'm keen that we move on so that everybody has a chance. So if I pass over to Sandosh for the next question, and thank you very much for your insights, Professor Carrier.
Thank you. So yeah, that segues nicely to the next question to Callum, which is, could you share insights from your experience, not only in research into rare diseases and implementing precision medicine for rare disease, but also your role in digital transformation and using data in broadening the reach of precision medicine and moving it from tertiary care through to the community. So we'll be eager to hear your insights on this.
Sure. Thanks, Sandosh, for the question and for the invitation to contribute. I think we touched on it in Holly and Kazu's introductions, but I think digital transformation is really an important piece of this, partly because of the fact that the fundamental problem with precision medicine is information flow. It's how do you identify individuals who need particular interventions, and how do you then get the information and the therapies to those specific individuals? And I think rare disease is just an example of how difficult that can be. And I think one of the lessons we learned is that the traditional approaches that medicine has used, which are very local, very expectant, we're waiting for patients to come to us, are really not fit for purpose. That in the long run, we're going to have to completely transform how we imagine data flows. And I think that's actually a really critical piece of how rare disease will inform this. It's probably the highest risk group of individuals. It's the place where there's been a substantial investment in developing precision therapies. But I do think it's going to be the leading edge of a very broad movement. And I love the fact that Kazu is doing this in hypertension, which is incredibly common condition. I think that the most important things are, as Holly said, how do we do this in a way that levels the playing field? We need to have very cost-effective, non-traditional approaches to collecting information and to getting data and information back to the patients, to the individual users of the information, and ultimately doing it in a way that happens long before they're ever actual patients. I think one of the biggest problems is that 9/10 of the population at any given time are not an active patient. So we have to be able to begin to collect information, data, and then the information from that data. And that means we need very different approaches to how we center the data, how we govern the data, how we give people control over their own data. But also think very broadly about the volume and velocity of the information, the data that we're collecting that lead to insights over time, and not look in obvious places for it. For example, I mean, you asked me how I see this developing. I actually think, for example, blood pressure will be eradicated as an endpoint, because ultimately the main reason we use blood pressure is to work out when we've got individuals on too much medication in the context of arterial disease. And what you're going to end up with is an index of arterial stiffness that has been developed, monitored in the individual probably from their early childhood right the way through their whole life, so that that individual is empowered to understand how to manage their own risk. I think the other things that are very clear are that going directly to patients transforms the way that we think about rare disease. I have some remarkable examples of trying to enroll patients in rare disease trials through traditional mechanisms. In other words, waiting for the actual physicians who are in the trial to identify those individuals, and then really almost abandoning that approach and reaching out directly to patients who've already self-identified, and finding that in a single web-based outreach, we could identify several hundred individuals that we had taken many years to even identify 50 or 60 similar persons in using prior methodologies. The final thing I think I'll say on this is that ultimately the key thing is exactly as Holly said, is empowering everybody to participate in the right way at the right time. So it's data collection, closed loop information return to the subject before they actually reach a medical threshold, but also giving that type of information to the clinician. As you pointed out, we're never going to have enough individuals to practice genomic medicine as a separate field. It has to be fully integrated with all of medicine. And once you start to add proteomics and metabolomics and all of the other parameters, we're not going to be able to parse medicine into individual fields. This is actually just common or garden medicine. And I think ultimately the real challenge with information flow is how do you build seamless platforms, systems that actually take information that starts off in specialty care, moves into primary care, but ultimately becomes patient-driven, patient-led intervention. And that, I think, is what we're going to see over the next few decades. I suspect it'll take much longer than I would like or than I would imagine. But ultimately, I think rare disease is going to be the tip of that spear because it is the place where the risk is highest and ultimately drives a sort of continuous loop improvement in the entire system.
Thank you, Callum. That was enlightening. But coming to the blood pressure example, it reflects the complexity of a phenotype and a disease, and a phenotype that's easily measured. If you look at blood pressure, the reason why we use blood pressure is because it's easily measured. And we are basing all our treatment based on evidence which originated from actuaries in the early 1900s. So when you say about, when Kazu says about blood pressure variability, and you mention arterial stiffness, and bringing large amounts of data in, it's mostly one of the sort of critical discoveries we need to make is what are the subphenotypes? What is true blood pressure? Because it's a net effect of multiple factors working together to produce a phenotype that we can measure using a cuff invented in 1896.
Absolutely, could not agree more. We're sort of trapped by these legacy phenotypes, which are actually remarkably narrow, very imprecise. I mean, think about it. Your blood pressure varies probably by 100 millimeters of mercury during the course of a day, even as a normotensive individual, running upstairs, you name it. And yet the largest effect size in any clinical trial is 3 millimeters of mercury. So you recognize that, and I'm not saying that those drugs don't work, they absolutely do work, but we need to begin to understand why that degree of imprecision has been tolerated, why that, and do it in a way that doesn't throw out the baby with the bathwater. We don't want to have to repeat all of those seminal trials. On the other hand, we also don't want to be stuck with parameters that don't really mean anything, even to the individuals who are working in the field in the long run. So thinking about how we do this in a very careful way is going to be critical. And I think that's part of the problem, is that there's not an easy way from here to there without us actually adopting much more systematic approaches to engaging stakeholders, exactly as Holly said, and thinking about this in terms of objective, data-driven improvement, rather than improvement that's driven, to be honest, largely by academic careers, rather than by systems-level improvements in the way in which data are collected, information is generated, and interventions are distributed.
So the other question I have about big data, and as we scale up data collection, as you mentioned, across the entire lifespan of an individual, we are going to require a lot of patient-generated data. And as you know, how data can be noisy, messy, and problematic if it's not collected rigorously. So I'm just wondering, what are your thoughts on how to overcome those challenges so that we can rely on the data that's being collected from quite different, using different devices and under different situations by individuals who are not experts in data collection? That's for Callum.
Oh, for me, sorry,
Yes.
I thought it was for Michael. I mean, I think, one man's signal is another man's noise. I think we have to be careful not to over medicalize everything. I think, for example, I've mentioned in prior discussions that, one of the best metrics, for example, of end organ damage in hypertension is the time it takes a patient to Bluetooth pair their blood pressure cuff with their phone. That outperforms a lot of other metrics. So I think thinking about where the data actually are is the first mistake. You need to look for the data, not imagine intuitively that we know where it is. So all I would say is everything should be driven by empiricism rather than by intuitive application of legacy homeostatic variables. I want to make sure Michael gets a chance.
Thank you. Yeah. So I'll hand over to Mark for the next question.
Thank you. And Michael's been waiting very patiently for the last question. And I would just say in the introduction, I'm still suffering from background envy because I was commenting on the wonderful backdrop, and he just casually said, "Well, that's just the view out of my window." So we can't argue with that. But your research and clinical work on extreme conditions is fascinating, and the knowledge it generates will drive both the science and the implementation of personal medicine. Wonder if you could share some of the lessons learned about precision medicine from humans in extreme environments.
Yeah, thank you for asking me to join this group. And I think there's a lot of fascinating questions that we've been trying to ask. And the best way to contextualize that is to look at first the groups that we work with, and because that ranges from human space flights. So the NASA Twin study would be an example of 1 year in space. All of the SpaceX missions that have gone up recently, but then we extend into military special forces, Olympic athletes, wilderness medicine applications. And one of the things that stands out in groups that we work with is they all have high expectations of high performance in their extreme environments, number one. But number two, they have very short careers quite often, sometimes 10 or only 20 years. And so we have to give them answers in this moment, right? We have to have clinical decision support for the clinicians now to the best of our ability. And we have to make decisions upon the data that we have. And so we're constantly in that situation of trying to give them appropriate advice, but individualize that advice based on the metrics that we have now. But what's, I think, really important for us in our applications is that we extend our work into extreme occupations, and that we extend that to the general public. So we are always learning from the data that's being generated in precision medicine from general clinical practice, clinical research and exploration, back to, let's say, extreme occupations. but then into our and lead environments. So we're in a continual process of trying to bridge that, because we understand precision medicine is very costly. It's very complex and not easy to apply. So how do we, in the course of what we do in extreme environments, build some of those applications that are useful to everybody, meaning every clinician and every patient or every individual, even in the wellness space, right? The healthy individuals wanting to remain well. So an example would be, we see space as an accelerated aging paradigm. So there's a lot of things that happen in space, such as muscle loss and bone loss. There's a condition called SANS, which is space-associated neuroocular syndrome, where you develop cotton wool spots, visual folds, and disc edema. And that's about 25 to 40% of astronauts develop that. And so that really lends itself to individual risk and identification of measures that would be precision medicine focused. And it does turn out that two genes stand out, MTRR and SMHT, part of the one carbon network. And so already space has informed us about particular targets to look at that might be relevant to Earth. In other words, space may accelerate that development, but these may be markers that we may look at on Earth that could become important. They just manifest over 30 years instead of 4 to 6 months. So some of these environments are accelerated aging paradigms, or they would bring out the phenotype often more quickly than would happen in an Earth-based environment. The other thing we look at is that in our precision medicine applications in extreme environments is that we're always looking at performance, but changes in performance also translate into safety. And so we learned that small decrements in performance can impact safety. So we're always looking at what are the elements that contribute to decreased performance, because we look at that from the standpoint of are there elements in the metabolic networks that are decreasing in efficiency that contribute to that performance deficit? And then what are the improvements that we can make? And so we're constantly looking at molecular networks, and we talk about from the standpoint of functionally characterized networks, where we try to look at, let's say, sentinel molecular measures within metabolic networks that seem to have greater influence than others. So we look at hazard ratios and effect sizes of certain components within molecular networks. I will use one example where we apply precision medicine in the pharmacogenomics space, and this would be, we can develop, and we do develop, individualized drug regimens based on pharmacogenomics, which was mentioned earlier. An example would be codeine and tramadol. So both are converted to morphine for their efficacy. And the genotype of the slow metabolizer is about 5 to 10% of individuals, and so the drugs don't work. And the other end of the ultra rapid metabolizers, that's about 5 to 10%, and they develop morphine overdose symptoms. And so that may not be noticed by someone who's functioning in on a regular basis in an office on Earth, but if you're operating in an extreme environment, could substantially impact performance if you were experiencing morphine overdose symptoms, let's say on a spacewalk or a special operations mission or something like that. And so we've really tried to individualize drug therapeutics for those operating in these environments. But again, we're always of the mindset that we're translating into general clinical medicine, because we believe that these high pressure environments are just causing some of these phenotypes to manifest earlier or more rapidly than they would in the general public. The other thing is the general public has the ability to dial back their activity so that when they experience these decrements in performance and things like that, they can dial back activity, which you can't do in an extreme environment. And so they manifest more overtly, quite often in an accelerated environment or an extreme environment. But I would just, from the translational standpoint, add one example when I use the word extreme environments. And so we have a nurses study taking place at Mayo Clinic of 200 individuals. And many would say, in fact, the nurses would say, that is an extreme environment. The way they describe their work is they're on roller skates the minute they hit the ward. And, as you know, there's a lot of burnout in those occupations. And so this is how we can translate from our more dramatic extreme environments into an operating environment like the clinical practice environment, where how do, or a surgeon who's got to be attentive for 8 to 10 hours in a long surgery. You know, we find in surgeons, they're often dehydrate, right? They don't want to urinate during a long surgery, but in some studies of surgeons, about 80% would say they expect their performance is deteriorating because of the lack of hydration. And we do find hydration in every environment to be one of the critical factors affecting decrements in performance. I'll just add one last few items here to think about. And so one of the teams that we work with is the Corvette racing team. And so we work with the drivers for the Le Mans series of races. One of the things we found immediately is in the 24-hour races, the pit crew, which consists of 10 crew members for each car, they don't get to alternate shifts like the drivers do. They have to work the full 24 hours of the race all the way through. So they came to us and said, you know we need to have a program like this for the drivers, but can you give us a program like this for the pit crew? And then they started to express all of their concerns about their individual medical needs. And I think that's important in our work, that we're, again, looking across the whole spectrum of individuals who have this need. And so we often look in terms of stratification, which would mean, what are the common within groups, right? What are the common molecular patterns, physiologic patterns, et cetera, that impact the phenotype, and there's shared measures. And then, of course, the individualization side of that, where we have to get very specific, and in particular about molecular analytics. But we always marry the molecular analytics to the behavioral phenotype measures, to the physiologic phenotype measures, and also to the morphologic, because we find, for example, in extreme environments, that dehydration is much more common in those who have higher body mass index and higher body fat in terms of their body composition. And so we really try to attend to those very basic things as well as the very complex. And so that really brings me to two final notes, I would say. We recognize that this is extremely complicated for clinicians, and I know that was mentioned by a couple of our other friends on the panel. And I think for those of us who are working at the frontiers of this, we really do have to address that problem of complexity for the clinicians. Obviously that comes down to training, but it is inherently complex, and it requires a lot of deep knowledge, and we do have to address that. We do have to solve that in some way. And I'll just close with a final thought on that. Is one of the ways that we've been addressing that, I don't think it's a final solution, but it is a useful solution, is development of digital twins. And so that's one of the areas that we're also working in. And so we've developed a cognitive digital twin so that we can accelerate that process of the input of the molecular and the phenotypic data. And that generates a pattern or a descriptive pattern of how to interpret that individual's clinical presentation and what would be the actionable items in that particular case, without having to understand all of the analytics, all of the molecular networks, all of the rationale for individual interventions. And we're also in the process of developing an astronaut digital twin right now, which has a smaller use, but the final point would be one of them is focused on bone in astronauts, which is a critical issue, but that one is being translated also into the problems of bone loss in terrestrial matters and general problems of osteoporosis, et cetera. So that's really a concise kind of condensation of some of the work that we focus in. And I would say, as a final note, we go from the adage of no one should ever enter an extreme environment with a knowable, actionable metabolic deficit. And whether we can translate that aphorism to the general public depends on a lot of things, including cost. But that is the approach we use in the extreme environment world.
That's great. I mean, thanks, Michael. It's so interesting that what would appear to be such a diversification has got such great lessons to bring in. We're coming towards the last 5 minutes, and we've actually got quite a large number of questions. So I'm going to pass over to Sandosh to ask the first question, but I think it's probably fair to say we are not going to get through all of them and we will look and see if there's some mechanism that we can generate some answers for the ones that we don't get to. But in the meantime, I'll pass over to Sandosh.
So the first question from the panel is a provocative question, which is, to drive adoption of precision medicine in the community, should health systems fund the individual such that the budget follows the patient? Could overall opportunity savings offered by early stage pre-disease management become the driver for adoption?
I think that's already being used as a strategy in many US health plans. People are incented to collect their data, to act on it as a means of prevention. So I think it's a very useful proposition. I think it's a good way of making sure that the data we're collecting in the rest of our lives impact our health. I don't think there are going to be enough data inside medicine to stratify at the right level. So we're going to have to pull data in from outside. This is one very effective way of doing it.
And in terms of budget?
I mean, that's where it's coming from. It's coming from the payers. So payers are incenting individuals to both, collect data on their activity, on their diet, and to modify that activity and diet and use that as a means of getting either discounts, or actually more classic for behavioral management is you get paid up front and the money gets taken back if you don't actually transact on it. So I think these are very, again, in every other industry, these are standard tools for spreading cost and risk and responsibility, something we have not done in medicine for a whole host of reasons, but something that's definitely welcome.
Yeah, it's interesting. I just want to jump in really quickly. I was thinking earlier, I forget what the question was now, or the comment, but talking about probably hypertension and behavioral change. It's why, like when we talked earlier about the stakeholders and who needs to be included, when you're talking about these sorts of things, including this one, you need expertise, right, in behavioral economics. I don't know the evidence base, for example, on how effective is incentivizing folks to change their behavior in the health realm, but I know there's a literature on it. It's just not one I know, for example, right? But I think it's really useful. It's just another example of where pulling in disciplines that maybe we don't normally think about in medicine, and social sciences is one, by the way. Those are the people who are creating behavioral interventions. So it fits really well with that core approach, right? To have all those relevant stakeholders on the ground. This might be another area. Yeah.
Thank you. Mark, over to you.
Thank you. And this is sort of a similar theme, but in areas where genomic sequencing is pursued at some level in the population, and it could have validated an informative polygenic risk score be used to enroll patients into some sort of continual monitoring program. How does the panel feel about that as a potential approach?
Again, I'm only jumping in because nobody else is, but the reality is already implemented in some very small pilots in a variety of sites worldwide. I think we've sort of traditionally used polygenic risk as an add-on on top of additional risk, but I think it's clearly mismatched for that. It doesn't perform very well in terms of incident events. It performs much better at the start of life because it's really good at predicting lifelong risk, and in that setting, very powerful for stratification into groups that may benefit from a variety of different monitoring strategies. And that could obviously vary depending on the disease area, the type of monitoring you're thinking about, but definitely something that's already being thought of and implemented by a couple of big genomics entities in the US.
Yeah, I think the question of polygenic risk scores, I know it's a very large one. It depends on also what are the actionable measures that would derive from understanding that polygenic risk score. Some of the very large ones that have extensive numbers of genes. We just finished a study at Mayo Clinic in breast cancer survivors, and it very closely matched the polygenic risk scores in terms of their the cohort distribution. But then there's other ones like cognition, where the ApoE genotypes really have a strong predictive value, along with some small other ones. But how do we make decisions upon the actionability, or what are the other metabolic risk factors that we can be confident in so that we can intervene in the presence of a polygenic risk score like that.
Well, I'm looking at the time, and I think that this has been an incredible discussion. I'd like to thank our panel today and everybody who's attended the webinar. I hope you've all found it to be informative, and we very much look forward to welcoming you to the next topics, which will be covering both the gut microbiome and also the role of AI, chat GPT, and machine learning in precision medicine. So, I mean, once again, thanks to everybody involved, and wishing you all wonderful afternoons and mornings, depending on your time zones. And thank you very much.
Thank you very much.
Thank you, everyone.